had a negative MPI. So these tests aren't doing a terribly good job of really determining you should go through the cardiac workup or you shouldn't go through the cardiac workup. It's really a bit of a toss-up. So that's the efficacy side of things. So what about the economics? So as I mentioned, we've got about 10,000 patients per day who are going to their physicians with symptoms that are potentially those of coronary artery disease. They are potentially something else, but they look like they could be coronary artery disease. Chest pain is the chief complaint in 1 to 2% of annual office visits in this country. But only 10% of folks are ultimately diagnosed with coronary artery disease. So there are a lot of people coming in with symptoms that look like they might be coronary artery disease, but in fact are not. Non-invasive testing is costing about $3 billion per year in stable symptomatic patients, and then another $2 billion per year is spent on invasive angiography. Okay. Yes?
Is the $2 billion extra that's spent on non-invasive, even when it's like gone negative, is that because there's such a low or such a high false negative rate?
Is the $2 billion partially because...
Extra. Because there's such a high false negative rate that they realize that the earlier testing might not be sufficient, so they don't want to totally rule it out yet?
Well, so the $2 billion is total. So that includes the folks who ultimately have coronary artery disease and those who do not. Now, again, you've got, based on the data from the New England Journal, you've got more than half of patients who are going in for those procedures who don't really need them. So, does that answer your question? Okay, so what's an alternative approach? So the Cora CAD gene expression test has been available for about 3 years now. We've run about 30,000 of these patients, of these tests. It's the first gene expression test to identify patients who can safely be identified to be unlikely to have coronary artery disease. So again, the value of the test is really in ruling patients out of unnecessary cardiology workups. I mentioned that women are notoriously difficult to identify with coronary artery disease, and Cora CAD is gender specific. So it's got particular value in the female patient population. This can be done easily in the primary care physician's office. It's essentially a blood draw, so any office that can draw and ship blood can use the test. They send it to us in Palo Alto. We send them back within 72 hours a score. And the score is 1 to 40. And you can see a visual right down in the lower right-hand side of the screen. Essentially, a score of 15 or less means the patient is unlikely to have coronary artery disease. Has less than a 20% chance of having coronary artery disease. In the case of a patient who's got a score of somewhere between 16 and 40, generally they will be referred on to cardiologist for further diagnostic workup. What we've seen from our 30,000 or so tests is that about 48% of patients have a score of 15 or less. So we're taking nearly 50% of patients out of unnecessary cardiac workups. The real value, as I mentioned, is in the rule-out capability of the test. And so that's demonstrated by this really high negative predictive value of 96% that was demonstrated in our second trial, the COMPASS trial. So what we know from clinicians is that with that level negative predictive value, they feel confident that when they get a score, that score is in fact representative of what's going on within the patients. So that's a little bit about different disease states, similar issues in terms of need for greater efficiency, but value of personalized medicine, and I'm certainly happy to take any additional questions as we go to the panel discussion.
Questions?
Yeah.
How much does the test cost?
It's $1,195, and we just last month received Medicare coverage, so now we're in the process of then going out to the commercial payers who, as you would expect, value the impact of Medicare coverage pretty significantly. Yes.
Question. Is there a time limit for the rule-out period? So if you do a test today and it rules you out, does that mean that rule-out is effective for 3 months, 6 months, a year?
Yeah. So that's a good question that we are grappling with currently. So in case folks didn't hear the question, how long can you be sure that the score is accurate? What we know from our COMPASS trial is that when we drew blood on day 1 and then 12 months later, 80% of people had a score that was essentially the same within the margin of error. But that's a question that we're trying to get additional data on of, how long does the score last, essentially.
Thank you.
Okay? Yeah.
Do you know what the gene codes for that you're recognizing?
We have an entire algorithm that I'd be happy to take you through. It's pretty lengthy, and we sort of started with about 250,000, and we've whittled our way down to a 23 gene algorithm.
Okay. But do you know what the protein is that it codes for? Is that clear?
I do not, no. You've got a commercial person, but our scientists, I'm sure, would be happy to chat with you about it. Yes.
In terms of creating awareness for this service, are you going to primary care doctor or are you going to consumer or both?
Yeah, so we've had 10 reps out in the field, and primary care is really the place where there's greater value. Generally once they get to the cardiologist, there's not as great value. As you can imagine, there are lots of primary care physicians out there, so we're just in the process of expanding from 10 to 20 reps, but that still will not get it done. So we are beginning to have some discussions now that we've got some coverage to make sure that we get the message out to patients and thinking carefully about how we best do that. Okay.
Just one, your COMPASS trial,
Yeah.
can you tell us something about it? Was it a multi-dimensional or was it just one group of people? Was it only in the US or all over the world?
It was only in the US. It was about 400 people, and it took a look at patients who were getting ready to go to MPI, and sending them into MPI or doing a core CAD test, and then taking a look at how people progressed through the sort of traditional algorithm versus a core CAD result. Thanks.
There we go. So hi, I'm Alex Bangs. I'm with Crescendo Bioscience. That's fun, change myself. So I'm going to talk a little bit about a quick background on our company, and then I'm going to kind of take a little step back and talk about personalized medicine a little more generally. The company's in South San Francisco. Locally, our focus is autoimmune diseases, and really we're aimed at working with rheumatologists, starting with rheumatoid arthritis and eventually getting into some of the other disorders they deal with, like lupus, ankylosing.
Can you speak up a little?
Speak up. How about if I get a little closer to the mic? I'm not a yeller, so I just. Just it's wanting to change by itself. Not too bad. Let's see. Just make advance manually. There we go. Okay. A little bit about the challenge of personalized medicine. Actually, for doctors, they've been trying to do this for a very long time. The challenge is the tools that they have available to them are pretty crude in a lot of cases. Drugs are run in very large populations. It's hard to tell what's going to work on an individual when you've got that person in front of you, particularly if the drug only works in 50% of people or less, when you talk about oncology drugs. I just want to relate a personal story of my own. A couple of years ago, my mother was diagnosed with gallbladder cancer. That had actually spread beyond the gallbladder. And a couple of things about that. It's something that happens, I think, on the order of 4,000 or 5,000 cases a year in the U.S. So it's actually a very rare disease. And as a result, there are not drugs that are targeted to it. And when it spreads beyond the gallbladder, the prognosis is actually very poor. one of the things, so I went into Google mode and what kind of things can you do, and actually had the opportunity to see a talk by David Agus, who works in oncology and personalized medicine, very interested in this field. And he talked about how cancer in the future really should be treated by the markers, by what the disease activity, not by organs. We're treating this disease by a 150-year-old medical system that's organ-based instead of really by more the physiology of the actual tumor. And he suggested a particular personalized medicine test to use that does a number of expression markers. Not one that's been mentioned today, it was something called Target Now. So we had that done for my mother, and it was interesting to see the physician struggling with not really wanting to order the test, and then when they had the results, not necessarily wanting to use this. And this is a physician at a regional medical center, a physician that had worked inside a pharmaceutical company, was a very technology-savvy person. So, we can have all these great tools, but until the physician understands how to use them, that's one part. I think I've appreciated over time that this physician also realized that the prognosis for my mother was actually very poor, and trying to put her through a lot of different therapies was not the right thing to do for a 72-year-old person who, in her view, had lived a pretty good life and was ready to be done. And so, when you look at the things that a physician is trying to take into account, they are trying to look at all the different options and what's going to fit best for a person. If a person's already on treatment, have they started responding? They're trying to predict, what this person is going to do. And in terms of the actual patient characteristics, there are a lot of things, not just the biology, that come into play, including, does this person have a preference about treatment, or, like I mentioned, about end of life, how they want to do? Are they able to deal with injectables or not? Because if they're not, then their adherence is not going to be very good. And there are financial considerations. So, I think that the talks we had earlier are great examples of, you gave some great examples of things that are negative consequences of doing certain kinds of testing and whatnot, and expense and whatnot, and those are all things that take into consideration. So the other thing is we start to produce more and more things, including, next generation sequencing, and the idea of having a whole sequence for everybody. It starts to get a little scary about what do we do with all of that data. And physicians already have a lot to deal with what's kind of on their plate right now. One interesting opportunity to help them would be, instead of you just sort of give them a tidal wave of data right away, would be what's useful for this patient? What's the next test I should do, both from a financial and just other consideration? For each of these tests has some kind of cost to the patient and the system. So there's something maybe we can do in that regard as to what's the right thing to do next. As I mentioned, it's trying to also get physicians to learn the technology and try and fit it into their workflow. Today they may say, my patients are doing fine. Maybe they are, maybe they're not, getting them to understand that. And then there are, of course, those problematic patients, or their caregivers like me, there was a recent, I don't want to say blog post or a piece about, patients that are Googlers and how painful they can be for a physician. But that's the reality they live in today. So a lot of times when people talk about personalized medicine, particularly people in the pharma industry, they'll talk about the right drug for the right patient, the right dose at the right time. So there are a lot of things that you can sort of be personalizing. I'm using the word treatment instead of drug because I think there are lifestyle interventions, there are device interventions, there are a lot of different things you can do. And I even mentioned the right diagnostic is another sort of choice to also be made. And I think that Pam gave a great example of that. So there's a lot of wonderful things that we're bringing to bear now in terms of technology on that side of things to help give data to inform that. The other thing is, now that you've made a choice for the patient, does it actually fit the patient, and are they going to start to do useful and interesting things with this drug and actually have it work for them? And there's a lot of interesting data there as well. If any of you are familiar with quantified self, I don't know if Melanie may touch on that a little bit, which is great. But there's a lot of interesting things that people can do, and increasingly tools are becoming available so that you can see, and devices for the home, for example, to see, are people taking their medications? Is somebody's lifestyle continuing, or are they starting to go downhill in some way and need some attention? So I think the opportunity for us is not to just produce these kind of different endpoint solutions, but also to integrate them all together so the patient and physician have a place to see how they're doing, and actually have a way to communicate together about that. So let me give you kind of in the area of rheumatoid arthritis, what that looks like a little bit and what we're thinking about. So just RA, give you a quick idea, this is a disease that affects 1.5 million people in the US, 2 million people in Europe. It's a chronic inflammatory disease. It tends to hit predominantly women, and the average diagnosis there is a juvenile version, but it also happens, the adult version is in about people in their 40s tend to get this. It's a chronic condition. It leads a lot of times to disability and sort of significant life impacts for people. So anything we can do to diagnose and treat the disease quickly, part of the idea is to try and get people under control quickly before their joints reach the point of disability and damage to the joints. Now, I could draw a graph very similar to that for diabetes, where the red curve would be glucose, and then the cumulative damage would be all the things that excessive glucose does to your system. The challenge, the opportunity in diabetes, or I should say why it works well in diabetes is because we have great measures of glucose. We actually know what's going on. It turns out in rheumatoid arthritis, until what we brought to market, there hasn't been great ways to do that and to really measure what's going on in a patient. So in a similar way to diabetes, we want to treat early, aggressive. Those are common targets that people talk about in RA. But how do you know a patient is doing well or not? If patients say they're doing well, are they really in remission, or do they still have what they call smoldering disease, where there's actually joint damage going on, but the patient can't feel it? So how can we measure better? So we created a panel. This has been on the market now for almost 2 years now, that gives you a score from 1 to 100 of how active the disease is in a patient. It's based on 12 serum proteins that are measured in our laboratory in South San Francisco. And then we use an algorithm to combine those proteins together. Not a trivial undertaking to do this. It takes a number of years to put something like this together. We did an early screening process with looking at a number of different markers based on literature and database and other areas where we said this protein has an interesting role in this disease. And over time, through a lot of different experimental analysis work, narrowed this down to a set of candidate markers that we went into more detail into development, and then finding 12 that we put together with an algorithm and then did a validation study to say, yes, indeed, this is predictive of disease activity in patients. And just, let me skip over this, but it's just, the markers play roles in different and interesting areas in the RA to give some diversity of patient and what's going on in patients. So I've talked a little bit about here, kind of on this side, the things that we can bring to bear, more data that potentially can be part of this equation. Another part of the equation for us is what can we do to help the physician understand this data and put it into context. So we've actually created a web-based system for not just getting the most recent diagnostic results, but starting to visualize it with other information. In this case, there's some medication information at the bottom so that they can see, here's the score for a patient over time, how is that changing, and then how is that matched with other interventions that have been done with this patient. More recently, we've created a system where they can actually look at their whole population. And the idea here is having this here on the y-axis, it's people that are at low disease score up to high disease score. But what's really interesting is seeing these patients, for example, that are high disease score and going higher. So the physician can say, oh, I've got some patients that are not really under control, and I need to potentially give extra attention to those people. So we're trying to make some tools there for physicians, and we're interested in getting more data over time and exchanging data with physicians to make this even more interesting. Let me flip over to the other side of this, is the patient side. And on that side, we've done a lot of discussions with patients, and one of the areas that's greatest frustration for them, and I think this cuts across a lot of different medical areas, but it's an issue in rheumatology, is a frustration about how well they're communicating with their physician. Are they being heard by their physician? Are they understanding what's going on and why the physician is doing certain things? Are they in agreement about the level of the disease in the patient and what they should do about it? Early research that we're doing with physicians suggests that having this report and having a real objective measure of how the disease activity is helping patients a lot in that regard. But we've done some work more deeply with patients, some design workshops and idea generation with them to say what could we do to help more with this. And that's led us to starting to build actual tools for the patients to use themselves so that they can do some of their own self-tracking of how they're feeling, issues like fatigue and morning stiffness that can be of issues for RA patients. When they come back with their doctor, they can share their information and have a combined discussion at that point. So we're working on affecting all of the different pieces of this, and we think there's a real opportunity to do this not just in RA, but do it more broadly in rheumatology, and obviously something that applies to a lot of other areas as well. As we do this, I think there are some things that apply broadly to personalized medicine in a number of different areas. One is, if we do this, you really got to take an approach that thinks about trying to integrate. And it's at the data level. I think in the future, we're looking at things where it's all, all protein measures, or gene expression measures, or it's all based on imaging. But we actually need to pull those islands together so that you have a better collection. You have, for example, or sequence information to say the predisposition and the actual blood measures to say now what's actually going on in the patient. Design is really important about this. I think EMRs are a great example of a tool that theoretically should meet all the requirements and is really crappy to use in a lot of cases and doesn't fit the workflow for physicians. So there's a real opportunity, and there are people in that space that are really giving attention to design. But I think that if we want to have effective solutions, we need to pay attention to the context of where it's going to be used. Analytics, I gave you a little snapshot of that so that we help people make sense of the data and try and do more things with the data we print. And the last thing I didn't really touch on, but I just want to mention in a couple different ways, is prediction. So it's something that Crescendo is interested in so that we can go beyond disease activity. We're able right now, for example, to help say this patient is responding well and they've got a this patient is responding well or not to a therapy because we can see an early response, say within a week or two, based on some of our pilot studies that suggest that we're able to more quickly show treatment response. But we're looking in the future to be able to develop tests to say, you take this test and we even predict which drug you should be potentially taking as a patient. One of the things that I did in a past life, this is work done several years ago, maybe you've seen David Duncan talk or hear him talk about his experimental man work. It's actually looking at using simulation where you really do integrate all of this data and use it to pick out of a simulated population all the people that look like the virtual David, if you will. And then one of the things we did with that was then make predictions about David's future, in this case heart attack risk, and what effects interventions can have on that. And just I'll explain this curve and then I will. So what we saw in David was this curve climbing upward said that based on his genetics and environmental factors, that if he gained weight over time, say an average pound a year, kind of creeps up on you over time, that his heart attack risk would greatly escalate. But if he actually kept his weight stable, that it actually stayed down very low. So he had, the other is if his weight increased but he took a statin, we predicted that his risk would be very low. So he had a choice. If he could continue to live sort of life as normal and increase his risk, he could manage his weight, or he could go on a statin, and he's chosen to manage his weight. So I think this is an interesting thing. If we start to do this integration, bring more complex modeling to bear, there's some really great things that we'll be able to do to kind of integrate all of these pieces together and do something better for patients and the physicians we're helping.
How's everybody doing?
Good.
So as we're starting, let me just ask, how many people have their 23andMe data? Handful of people. But has everybody heard of it? That you can order your own DNA online for $300 and you get 1 million different SNPs in your own DNA. And on the website, 23andMe talks about how these different SNPs relate to 200 different conditions. related to drug response and health risk and so on. Alex also asked how many people are familiar with the Quantified Self movement and meetup group. How many people have attended? So again, more so on the Quantified Self than on the 23andMe genomics. And I'll be discussing more of these in depth. It's a pleasure to be here. Thank you, Rhonda, for inviting me. I'm going to be sharing how our DIY genomics health research studies relate to the topic tonight, personalized medicine and you. The slides are available online at slideshare.net/lablaga. So I would submit that one of the key public health challenges of our era is the realization of personalized preventive medicine. We're tackling the problem in a number of ways, both in the 80% of the condition's life cycle before it goes clinical, and then also once it is clinical. What we've already heard from this evening is solutions in the case of personalized medicine when it's already been recognized, or at least symptomized in patients, such as the personalized molecular diagnostic tests that we've heard about tonight. On the other side, before conditions go clinical, could be a nice time to work on them so that they may not even become clinical. And there are a variety of different solutions in this area already, ranging from the very light touch, say through mobile health apps, of which there are over 7,000, to more intense engagement in activities such as health collaboration communities and crowdsourced health studies. This is the area that I'm more focused in, where we are quite familiar with the social network. We have LinkedIn for business, Facebook for social interactions, and many different kinds of health social networks now, which are online interest communities where members may share information, track their symptoms, and discuss different treatment options. Just as Clay Shirky predicted, not only are these online communities initially about sharing, but they eventually move to more of a collective action kind of activity. And that's been happening now in the form of health collaboration communities, exactly like the Quantified Self, which has 10,000 members worldwide in 80 different meetup groups, and just had its 3rd annual conference at Stanford very recently. My group, DIY Genomics, is also in this collective health space. Our basic research model is towards the goal of preventive medicine. We are conducting predictive risk profiling, determining baseline markers of wellness and their variability, and testing different personalized interventions. In our studies, we're always looking for a minimum of N equals 100 participants. We have 2 independent subject matter advisors on each study who are clinicians or academicians in the area. Our studies are supported by IRBs, and also a new category of reviewer, the citizen ethicist, that is also independent and reviews our study protocols to make sure they pass the smell test. Our generalized research hypothesis is that one or more genetic polymorphisms may be resulting in blood levels or other phenotypic conditions that are already out of bounds, and which may be improved with personalized solutions. This is exactly the format of our first study, which was published in 2010, looking at vitamin B deficiency. In this study, we looked at 2 genetic SNPs in the MTHFR gene, which is related to vitamin B absorption. And then we tested vitamin B and homocysteine levels in the blood. What was most interesting initially was finding out that 75% of our healthy adult cohort was already at higher than recommended levels of homocysteine. And this is related to cardiovascular disease and dementia. What we also found was that personal interventions were very effective at bringing blood levels back into bounds within 2 weeks. And for most people, what worked best was just the regular drugstore vitamin B multivitamin. And for a couple of people, the specialty active form of vitamin B worked better. So what was surprising to study participants was that exactly how effective and quick and a personalized intervention could be, and that N equals 1 in terms of what worked best for the individual, not at all. What works on the average may not work for the individual. So like most sectors of the economy, health is a big data problem these days. And as other talks have mentioned tonight, that we're having more and more different health data streams that are starting to become available and that we need to integrate